psychiatrists that are our witnesses today. I'm wondering about the plan, what sounds like a really sound plan of carrying care beyond the acute event in a follow-up methodology. Who should be doing this? And are the countries that you are talking about that scale up these sorts of plans that carry on care through hospitals or clinics or whatever, are they also experiencing acute shortages in psychiatry services, trained psychiatrists in their countries? How they're getting around an absolute finite resource of psychiatrists that may be smaller than it needs to be? Because that's one of the problems that we have. I'm a physician. I see patients, primary care pediatricians. I see patients, and often if there is an acute episode, we have nowhere to go in that follow-up realm. Are we asking primary care trained up individuals to carry on care? And how do we escalate up to the necessary appropriate care? What's the plan around that follow-up that you would recommend?
If I could,
yes.
If I could start, I think it's a very good question. There are levels of, in terms of screening, we know that it's not cost effective to screen an entire population. So I think starting there, we need to identify the at-risk groups better. And just as we would do with cancer, for example, somebody with a stage 4 treatment would be seen more frequent, a stage 4 cancer would be seen more frequently or would have an extra level of treatment. I think we haven't in our mental health services identified who needs intense treatment where the specialists don't do so almost primary interventions, they do tertiary interventions. And I think that we do need more resources, but we also need to be more screening, as it were, within our own profession, I think.
Dr. Mann, could you comment when you talk about these strategies around follow-up and scaling up follow-up to a population?
There's no question that more resources have to be deployed, and it costs money. There are studies from the UK and Denmark that demonstrate that when there is an investment in infrastructure in terms of more staffing, training more people, more clinic appointments, continuity of care, that is proportional to the degree of improvement in terms of dropping suicide rates and suicide attempt rates. So you kind of get what you invest in, provided you invest in the best places. And what you're suggesting or implying in this follow-up approach automatically selects the highest risk patients because they're the ones who are presenting in that crisis. So you're not giving this to every patient. You're focusing on what you can detect quickly as the highest risk patient. And we do know that their greatest period of risk is in the first year after they leave, after that crisis. And if they can survive that 12-month period, their risk of suicide drops very meaningfully. So we need to get them through that crisis period of their lives.
I have a follow-up question, Madam Chair.
Just quick one. Yes.
The question is to you, Dr. Chireki. You made mention the fact that there was little consultation around the building of this framework for key agencies like CIHR and so on. There is an action plan currently being developed. Have you and others, these agencies, been consulted?
So I thank you for the question, Senator. I'm not sure what action plan you're referring to. There are, if that action plan is linked to the framework, so that's the one that I mentioned about. Yes, is this National Canadian Agency on Research.
Talking about is the one Minister Bennett informed herself when she was a witness here, that they're in the process of developing a suicide prevention action plan.
but that's not a recent action plan.
I'm afraid we're going to have to stop it there. Perhaps we